Hey everyone, welcome to Grand Rounds. Today's going to serve as an introductory lecture today where we're going to talk a little bit about the format, and then I'm going to give you guys a sample case that I'm going to articulate and go through. But this is something that the goal and what I hope that we do with this is something that we continue to integrate throughout the musculoskeletal semester and make sure that you guys have an opportunity as you gain more knowledge for different regions of the body, have more opportunities to apply those and really challenge clinical reasoning in the progression. So that's our goal here for Grand Rounds. My name is Justin Zych. And as you guys may remember, I had the chance to work with you in interventions. And during interventions, I went back to kind of think about how I could jog y'all's memory about me because we didn't, obviously, I'm not here in front of you. So I went back to slides to see if I could find some notables. And guys and girls, we were all over the place. From Angry Cat to sharks with lasers on their heads, waves, and watching Dr. Sprague do his best attempt at spotting. So I'm going to try to narrow things in a little bit more in musculoskeletal. I'm really excited about this content. If you guys remember, this is an area that I went through some specialty training as well as some fellowship training. So I'm very excited to be a resource for you guys and help facilitate some of this clinical reasoning here. So what are grand rounds? Grand rounds are something that you will see in the working world, hospital systems, outpatient systems. Hopefully most settings that you guys are in have some form of a grand round that exists. But essentially what it is a presentation of a real life clinical case. It highlights clinical reasoning either for an evaluation, an intervention, or prognosis, something that's either new and you think may be beneficial for people to be exposed to it, or just a really good example of clinical reasoning that other people may benefit from altering their practice patterns. And as you'll see here in the next slide, we're going to try to break things down specifically in 3 different ways, which I'll explain here in a moment. So the format for today in particular is we're going to focus on an examination piece. And for that examination piece, again, I'm going to go through with you guys so you can take a deep breath because I am going to have you guys go along and pause and do your own moments of reflection. But you're also going to have a chance to hear from me and hear from some of my reflection as I try to articulate this the best that I can. So what's going to happen today is I'm going to start by showing us intake paperwork for a patient that I have seen before. We're going to stop. And just like the puppies are doing here, we're going to reflect and reflect on our hypotheses, any sort of differential diagnosis that we have, reflect on how we're going to go through the next steps. And then we're going to do that. We're going to go through and ask specific subjective questions that we reflected on, stop once we have that information, reflect again, and go through and see, based off of the information that we have, how has our hypotheses changed? Has something been rank ordered higher versus lower and vice versa? And then we're also going to go through afterwards and then do an exam, tests, and measures, stop, and then hopefully reach a point where we have a really refined clinical impression or hypothesis that we're able to use the reasoning that we've gone through. Okay. Now, this is a good opportunity to make sure that if you guys haven't pulled it up yet, go ahead and pause this for a moment and pull up the Grand Rounds clinical reasoning template. We're going to use this during our breaks to help guide your guys' thought process and learning, not only today, but throughout the semester. So go ahead and pause if you don't have that now and make sure you have it pulled up, either printed or on the computer with you. So for today's Grand Rounds, we are going to focus on the areas that you guys have been exposed to this point. So as far as I have been introduced, you guys have the opportunity to go through all of these things. But at the same time, these are real life clinical cases and real life patients. So while we're going to try to see what we can do to have you guys reason within these 4 areas, everything's fair game. This is someone where real life, I may not have a complete mastery or an understanding of a specific visceral pattern or pain, but it's still our responsibility to know if something doesn't fit that left column, the regions that you've covered to this point, and make sure that you know how to properly address or refer them to somebody else that has. So technically everything's fair game, but I do understand where you guys have been up to this point. Okay, so here's the first case. And as, again, just so you guys are aware, The first case is here. What we're going to do with it is it's just intake paperwork. So I have not talked to the patient yet. I just got this paperwork, and this is going to be reasoning before we even see the patient, who is a 30-year-old female. You can see her pain rating scale scores below. She was given a NDI and a quick dash with the scores there, looking about 36% really for both of them. Past medical history, does have a history of hypertension, dizziness, and cancer. Works as a commercial real estate director, and we do have a copy of her pain diagram. And it looks like here the pain is, I can't really tell if that's neck or shoulder region, but it's focused a little bit more on the left side. So that's all the information that we have so far. So I want to make sure everyone has the Grand Rounds clinical reasoning template up. And what I want to do is we're each going to go through this individually, myself included. We'll take a break, we'll come back, and then I'll do my best to try to articulate through my reasoning for my answers. But what I want you guys to do is go through the first two questions. First one mentioning list all potential sources of pain. The key word in there is all. I want us to be as inclusive as possible and really start to wrap our mind around the thoughts behind what specific tissues could be involved here, and really trying to think of everything that could be included. And then afterwards, go through and really start to list out our top 5. So starting to get a little bit more specific towards what we know about this patient so far. Clinical impressions, going from most to least likely. And don't worry so much about the order. As you'll see as we go through, these orders may change. And even if you don't have them in the correct order right now, that's kind of the point of the exercise, is we're trying to work on pattern recognition and identifying why certain people ranked things a certain way. So don't worry too much about that. I just want to see where everyone's head is at this point, or have you really see where your head is at this point. So go ahead and pause the presentation, and when you come back, I'll go through my answers. Okay, so here are my thoughts. So as far as the potential sources of pain, that's essentially a list of everything that could cause pain here. So we're talking bone, muscle, cartilage, ligament, tendon, joint or joint capsule, even non-musculoskeletal tissues such as visceral structures like the heart, the lungs, or the gallbladder, who all have a referral into that area that was on the pain diagram. And those are, I would say, the main areas that could potentially, or nerve. We can put nerve in there as well. I think that's a great example. As far as my differential diagnosis, I decided to put on more than 5 just to be a little bit more inclusive, but then also open your guys' eyes to some other thoughts if you didn't already put them on yourself. So things that I put on there were a rotator cuff strain, a cervical facet dysfunction, a cervical radiculopathy. I want to be careful about saying cervical radiculopathy because that's not going to be one of the lower segments. That would have to be something that's higher unless they haven't told us about the nature of their pain or how their symptoms travel based off that diagram. So it's still in there, but based off of the location, I'm not thinking it's a C6-7 or anything like that radiculopathy. Could potentially be a peripheral nerve entrapment. Again, that boils down into the nature of the pain, which we'll ask and get towards in a little bit. It could be an upper trapezius strain, tear, or anything like that. Could also be a couple red flag conditions that we need to refer out for, such as a heart condition, so like angina or anything like that could be in play here. A lung condition as well. The spleen, again, we talked about those referral patterns, and then cancer as well. Pancoast tumor comes to mind, but really any sort of cancer could be involved here. Also, 2 that I left out until I remember that you guys went through thoracic were thoracic facet as well. Rib dysfunction or the muscles, the parascapular muscles that could be strained in that area as well. So going forward, now we're going to go ahead and start the subjective exam. And I'm going to start it pretty much by starting with a very generic open-ended question here. So to the patient, tell me about what brings you in today. Her response: My left shoulder pain started 2 weeks ago after moving into my first house. Since that time, the pain has continued to get worse. Work hasn't helped. I'm working extra hours and have been working remotely for the past month. My partner has taken over all overhead lifting, but it is sore if I do any continuous lifting over 30 minutes. My partner is a PT in the hospital and recommended I see you first before seeing a medical doctor. So again, I want to take a brief pause and have you guys go through and list out the additional questions that you have. So we have a lot more information now. And I like the fact that we put that in paragraph form because it's important that we allow the patient to talk through their open-ended questions. There were multiple times that I wanted to stop and clarify and quantify some certain things that she said, but it's important that I, keep in mind those questions, but after she's done, thoroughly explaining in her words what's going on, then we can come back and start to be still open-ended, but eventually getting into some close-ended questions. So go ahead and pause here, take a few moments and go through and write down some of the additional questions that you would have for this patient. Okay, so she gave us some really good general information. And what I want to do here, just because I have two roles that I want to do on this slide, I want to tell you guys my thought process behind the questions that I'm asking, but I also want to go through and give you the answer or give you what the patient would answer to these. So just to keep everything organized, what I'm going to do is I'm just going to start with my question thought process, and then I've got a couple notes that I'll summarize some things on as far as what she said. So again, she gave us some really good general information, but I was kind of itching the whole time to interrupt and try to get a little bit more clarity and to see if I could get a little bit more specific with a couple of things. So I'm glad I didn't. But again, even starting with the first thing that she said, the pain in the left shoulder started 2 weeks ago after I moved into my first house. I don't know yet at that point if that was due to a trauma, so whether that was when she was lifting one specific thing or if it was something where she was sore the following day. So at this point, I think I'm going to get a lot more information if I keep things open. So question that I may use to clarify after that is, can you tell me a little bit more about the exact time of pain onset? And leave it there. Yes, I do want to know if it was next day or traumatic, but I want to keep it open and figure out if there are some other things that I may not even be thinking about that are still really important data points for us. I also want to clarify the location that she mentioned. So she put in a bunch of X's, and I want to make sure, are those X's that sometimes it changes? Is the nature of the pain something where it radiates? Or is it always in that spot? Is there one spot that hurts the most and then it kind of dully radiates out? Or does it all stay there? So that location is really important, but it also gives us really good insight into the nature of the symptoms. So I want to see if I can get some more information. So I would just ask her to clarify the exact location of her pain. Hopefully that gives us a really good answer and she answers some things on the nature of the pain. But if not, I would ask and follow up on using the nature of the pain. And I think that question is really important. And one thing that I've found through my mentoring sessions and when I mentored others is probably one of the toughest questions, because as we're starting to think about this, we have a question or an idea of why we're asking that question. I'm asking nature of the pain to see if it has to do with nerve-like symptoms. So make sure that when you're asking that, you're not immediately saying, can you tell me about the nature of the pain? Is it a burning pain? Is it aching? Is it sharp? Because we're taking an open question and we're pigeonholing it to answer our question. Okay, so really bite your tongue and just ask, can you tell me about the nature of the pain? How would you describe the pain? And allow the patient to kind of put it on a platter for us. Okay. Also, I want to know what makes the pain better or worse. Not only if it has a time period throughout the day, but what are aggravating factors? What are factors that make it better? She mentioned a lot about her work environment. I want to know more information about that. And again, and I don't know exactly what I want to know there yet, but it sounds like it's changed. And it sounds like it's not going well now. I don't know if it's ergonomics. I don't know if it's anything else. So I'm just going to ask, can you tell me more about your current work environment? And see what that gets me. And then also she mentioned that that her partner had been helping her more with activities like lifting. Now, is the partner helping more because you physically can't lift over your head, or are they helping because it's convenient and they're more than willing to? Why are they helping, and what are you limited in that regards? And then segueing further, can you list a couple activities that you are limited in right now? And while that information may tell us some things diagnostically, we're also getting data points for once we decide to create a treatment plan for this patient. So this is helping fill out that middle box of the ICF model for us. And then, going back to, again, trying to fill that ICF box and be as comprehensive as possible, what are the goals? Well, what goals does she want to get out of coming to therapy? So again, those are the questions and part of the reasons why I would ask. I'm going to give you guys some of the data points for her. Her goals is she wants to finish a workday without pain, be able to return to her HIIT classes, and not have pain in the morning. Some of the aggravating factors for her, she mentioned work. Specifically, it's sitting for the long periods of time. HIIT workouts. She does a lot of HIIT video workouts. End range cervical rotation, so turning her neck as far as she can to each side. Sleeping on her stomach or on her left side, and prolonged sitting. Relieving factors that help her, supporting her head on the back of the chair or using her hands to almost brace her neck and give it a break. Using heat, and then doing what she called head circles, where she's just kind of rolling her head around like crazy. Other things that she mentioned as far as the nature of the pain is she's stiff in the morning. It gets better in about an hour or so. If she does physical exertion, it gets worse, and that's where she talked about lifting. She's not limited in her lifting. She can lift overhead, but as they're still moving a lot of their boxes, her partner is taking the responsibility of doing a lot of that lifting, although she could if she needs to. At times her head feels heavy, and she feels like now she has to turn her whole body when looking over her shoulder when driving, especially when she's looking over the left, which is the more painful side for her when she's turning. When she talked about the work environment, it's because of the quarantine. She's not going into her work environment right now, so she's trying to create a dual screen system like she had in her office. So she's propping up some screens on textbooks and having difficulty with that. She's not sure if she propped them too high or too low. She hasn't had a chance to buy a new desk chair yet, so she's using a kitchen chair, like a firm wooden kitchen chair for the time being. And as far as other information, I think those are the main things that she brought up that we need here for today. When asked about her work, so commercial real estate director, she's not out in the field as much, so most of what she's doing is behind a computer or making phone calls throughout the day, and she tends to use her left side, so she puts the phone to her left side, and notices after doing that for a long time that it can be painful as well. Hey guys, sorry, I was going through and reviewing and realized that I teed up a couple questions and didn't give you guys the answer for. So the question about the onset of pain, she was sore the following morning. She didn't have a specific event where she heard a pop. If we did hear a pop, we would maybe be more concerned, not necessarily about a rotator cuff strain, but maybe something more specific, shoulder pathology, maybe even labrum or rotator cuff tear. She always described it as a dull ache. The sharp pains came specifically when she was trying to turn her head as far as she could to the left. And I didn't mention this before, but really important to use this almost as a pre-screening tool. Let's make sure that we ask about any sort of strength or sensation loss. Especially if we have an inclination that there may be some cervical involvement, we want to make sure that it's just cervical and not anything going down into the periphery. And that also helps with our radiculopathy thoughts. She doesn't have any strength, grip, or strength loss at all. No sensation loss. So everything is clear from there. Let's use another pause opportunity here to relook at our list. So going back to the clinical reasoning template, the 3 questions after the subjective interview. Now rank your top 5 clinical impressions from most to least likely. What has changed, if anything? And if anything changed, what information resulted in that shift of likeliness? After that, I want you to go through and either, if you're using the computer or if you're writing on it, go through and write out what your examination for this patient would look like, including not only the sections of saying, okay, I would do active and passive motion, but specific tests or things that you would look at. And then we'll come back through and go through part of those here in a moment. So for me, when I was taking a look at this, my order changed. Initially, I had rotator cuff near the top for me. My order changed. So now I have the upper trapezius strain as my number 1. Number 2 is cervical facet issue, and then 3 is rotator cuff strain. Rotator cuff strain went down for me because she said that she could physically do it. She didn't mention anything as far as specific overhead pain parts or anything that would make me think that the rotator cuff is not firing efficiently, and her pain pattern doesn't match the normal pain pattern that we would have for a rotator cuff issue. So I shifted that down. I put cervical facet up higher because specifically some of the things that she mentioned with turning her neck from the side to side. If, for example, if she's turning her head to the left, that is putting more compressive pressure on that joint. That joint is approximated or closing, depending on the terms you guys are using. And when that happens, that could be pain provocating. Okay, and she did mention that that left rotation is painful. But at the same time, that could also be something that could bother her upper trapezius. So for that reason, upper trapezius is still high on my list at this point. Okay. Now, I didn't go through and write out the examination flow. I have this slide that that I use. So essentially, when I look at this patient, these are the check marks that I'm going to take a look at. So we already went through the subjective portion, but it's going to be important that we start with observation, do any screening based off of other areas that we think may be relevant, then go through mobility testing. And for me, I put mobility testing as a broad term here. Mobility testing is active range of motion, passive range of motion, passive physiological, and passive accessory motion as needed as well. Muscle performance, strength testing, MMTs, things like that, palpation, special tests, and physical performance measures. And as you can see here, we had the funnel in the last slide, and I have this triangle pointing down because with our subjective and observation, we're very broad. We're looking for everything. And as we screen, we're again broad, but as we start to go further and further down towards special tests, we're getting pretty specific. And that's the point when we think about how we're organizing our exams, is we want to start by being as inclusive as possible and seeing what we can throw out, what we can rule out. So we have more things that are potentially sensitive at the beginning. And then as we go down, we're trying to get more specific to help rule in and confirm some of our hypotheses that we have at this point. So let's start with observation. So here's how she looked here in the clinic. Specifically, she has that forward head posture, anteriorly tilted scapula. Looks like her shoulders are slightly protracted. On the right, I always like to call him out. This is one of my friends. I took this and said I would hold it against him every time. So I have this weird moment where I always text him and say, hey, is it okay if I use your picture again in this lecture? And the whole time, I need to stop and start calling him because I know that as he's reading my text, there he is, head down, in that awful position. So that's how I've also found this patient in the waiting room beforehand on her phone in that very dependent forward head posture position. So here from the active range of motion, here are some important things that we did. And I'm skipping active to active range of motion because all clearance tests were negative. So if you chose to go through and do, well, actually, let's back up for a second. So if we think about clearance tests that we would do here. Certain clearance tests for the cervical spine could be cervical ligament, Canadian C-spine rules, but you have to stop and take a look at some of the information that was in this case. Now, if we had the opportunity for every single person, does it hurt for us to go through and take the few seconds to do that? Absolutely not. It doesn't. Going through and ruling out a fracture is good. But think about some of the information that she told us and some of the criteria that are in the Canadian C-spine rules. She's already told us enough to essentially rule her out based off of that. She's sitting in the room, not uncomfortable at all. She was, didn't have a fall or a traumatic incident. No point tenderness or anything that would make us stop and say, okay, this is something that we need to rule out for fracture right away. Again, with ligamentous strain, no traumatic incident, nothing that potentially led us towards any symptoms that could get us to the point of, the 5 Ds and 3 Ns that would have us concerned of any sort of upper motor neuron issue or cervical cord compression because of ligamentous strain. So I wasn't as concerned with those. For the shoulder, did go through and just do some active overpressure in a certain positions. So flexion with overpressure, abduction with overpressure, internal external rotation with overpressure, and all of those were fine. So if it's not on here, it doesn't mean that I didn't do it. I'm just trying to put in the significant data points for you guys. So all screening was negative. In cervical active and passive range of motion, the active motion that we had here, she had tightness in the base of her neck during 50 degrees of flexion. Extension for her, she was able to get to 75 degrees, but did have pain in that area that she marked, that kind of left posterior shoulder area. Rotating, she was able to get to 70 degrees to the left, but there was pain on the left. Rotating to the right, she did have some tightness on the left side of the neck as well. Side bending to the left, both directions, she was able to get 45 degrees, but again, had pain going towards that left side, and then a little bit of tightness when going towards the right side. Looking side by side here and comparing passively, you can see that she did have more flexion motion passively without pain. So that to me tells me that there could be a muscular influence based off of that. She also had an increase in rotation range of motion, went from 70 and 75 to 80 degrees respectively, but still had pain in those areas in the left side of the neck. And then the same thing for side bending, gained a little bit of range of motion going towards the right. So that shows that whether, not necessarily that that's the main cause, but those are a couple of things that show that anything where the joint is in a position where it's more approximated or closed down did result in that same left-sided pain. But it's also showing some signs that the upper trapezius, especially on the left, is a potential pain source or at least tight. So we'll have to go through more tests and measures to see what we want to do to put some context into saying which one is more of the pain provocator. So now looking at passive physiological intervertebral motions. C01 was limited in flexion. C12 was limited towards the left for rotation. C56 had a little bit more mobility, but it was painful. And then going down into the thoracic spine, T2 through 4 were hypomobile for extension, rotation, and side bending. Passive accessory intervertebral motions. C01, again, that left side was painful, and there was actually a little bit of radiation to the head as you continued to do more of those. Same thing with C12, a little stiff with a central PA. On the left side, doing a unilateral PA, it was painful and again had some slight radiation to the head. So, and that's kind of an odd finding because that wasn't in her pain diagram and nothing that we talked about. So, while we're gonna put an asterisk by that and keep it in mind, I want to make sure that at this point we don't panic and we don't jump into saying, okay, let's try to diagnose these headaches that I found. We're identifying structures and we're trying to provocate pain. And I want to make sure that we're still sticking with their familiar sign, but being very aware that that's still important data for us, but not enough to have us shift and get out of that examination flow that you guys wrote from before. So going down to C5-6, again, the CPA was painful, and the left UPA was painful and created that same pain in that back side of the shoulder by the scapula. And T2 through 4, her CPAs were stiff. She didn't have any pain, but they were stiff. Looking at muscle length tests, on each side, a lot of these were bilateral findings. Pec minor, sternocleidomastoid were tight bilaterally. The SCM on the left was a little tighter. Upper trap bilaterally were tight, and they were about the same amount of tightness. The left had a little bit more pain when going through and palpating. And then the scalenes were tight bilaterally. From a muscle performance standpoint, when going through the craniocervical flexion test, she was able to do 24 millimeters without compensation. As we tried to go higher, she had to compensate through it. And I tried to set up the deep cervical neck flexor endurance test, and as soon as I let her head go, so again, that's the tuck and lift your head up and maintain that position. As soon as I let her head go, she pretty much started aberrant motion and couldn't hold it. So I marked that as less than a second. Okay. So after going through the final clinical impression or the examination, I want to go back to the clinical reasoning template and give you guys just a minute to go through and, again, rank your top 3 clinical impressions from most to least likely. And think about, again, if there were any exam findings that resulted in a shift in the likeliness for a diagnosis. So I'm going to give you guys an opportunity to pause this here, and then we'll come back in just a moment. So for me, my order did change. My order changed just slightly from where it was from before. My number 1 now was a left-sided C5-6 facet dysfunction. So I was able, due to the CPAs and UPAs, to be a little bit more specific on location. The main findings, actually, give me a second. I'll go to that in the next slide. Second for me was upper trapezius strain. While it's obvious that she has some upper trapezius tightness and guarding, I'm not comfortable saying right now that that is her primary source of pain. A lot of times when we run into muscle guarding, that could very well be the body's reaction or a result of an underlying pathology or a musculoskeletal problem. So for me, I think that the upper trapezius tightness is important, and of course will be really important as we get into our interventions to try to loosen that up. But more things in the exam seem to fit a little bit clearer with that left C5-6 facet dysfunction. And then third on my list was rotator cuff strain. After going through the screening, pretty much ruled that out, just based off of the fact that there were no shoulder causes, and everything that was causing the pain was musculoskeletal and in the neck. So here's what the final clinical impression was, and this is what we went through and treated, and she did end up getting better. I put on this figure because it's important to, again, realize that, yes, cervical facets with CPAs and UPAs can hurt locally, but facet referral patterns are really important to continue to remember and keep in mind. There are a lot of times where I'll see somebody and I'll get a referral that says shoulder pain. I'll get a referral that says trapezius strain. And that's great. I mean, that gives me a location for where they're feeling the pain. But we have to keep in mind, as you can see here, the neck really has areas that are extending throughout the head and the kind of scapular region. So if we went through and only treated the upper trapezius here, they'd probably feel better after our session and maybe for a couple of hours. But if we're not addressing the neck with this patient, if we didn't go through and do a thorough examination, including the neck, I think we would have really missed the boat here. So I like that example because we included everything in, and by doing that, we reached the point where we can say confidently that this is more of a primary neck issue with some muscle tightness. All right. Now, I tried this joke out a couple times with last year's group, and it was about 50-50. And I was disappointed. I thought everyone would have seen this and known what it was, and it would have been roaring laughter. So I don't know if anyone's kind of snickering to themselves right now. If not, you can YouTube Nature Walk and go through it. And then whenever you see this slide again, it'll be hard to unhear it without his voice. But I like this because it's a really good segue. So great. We have a good sense of what the tissue is, what the area is that we're trying to go through and treat. But now what? And I had to put it back in. I think in every single lecture that I gave you guys, I tried to make sure that this slide made it, if not 2 times, at least once. So it's still relevant. When we're starting to think about interventions, what tissues do I want to target? We just did a really, really comprehensive job of trying to answer that question by doing a really good exam. And then what effect do I want to make on this tissue? Okay, so if we're talking about a C5-6 facet dysfunction, could it be that facet joint is not doing well with the increased compressive forces, creating a little bit of cartilage dysfunction, and they need more manual therapy to improve how that joint is gliding and keep it lubricated, and then work on improving the muscle tightness that we found with the muscle length tests, and work on improving some of the motor control through muscle performance. And then always thinking about how will I know if the intervention was effective. We did a good job at isolating these things through examination. Make sure that we're going back to those same tests and measures as we're doing treatment. And then we also have the ICF model, which I know you guys have seen by this point. So we did a lot of, we talked to this patient about everything from participation with her HIIT classes and work to specific activities, and then going through the exam with body functions and structures. We didn't spend as much time going through personal factors and environmental factors, but could it be that this person ended up having to change her environmental factors because of something out of her control? I'll use a very relevant example right now. What if she's currently under a self-quarantine, or her work is saying that you can't go into the office, and she's stressed because she's trying to create a similar environment to what she had before, and leading to some pain. So important that we're keeping that in mind. And yes, we were very bio-focused today. We focused on a lot of tissues, but there are some potential psychosocial variables that may be addressed as you continue to keep going. And I like to include this. I believe you guys have seen it by this point, but if not, these are 4 treatment-based classifications for patients with neck pain. So you can see here neck pain with mobility deficits, movement coordination impairments, headache, and radiating pain. So with this patient, we avoided the radiating pain and avoided the headache. But I think that they could fit well within the area of neck pain with mobility deficits and neck pain with movement coordination impairments. This pain has been going on for, 3 weeks? 2 weeks? 2 weeks. So she's transitioning into this subacute phase. So you can use this and take a look and say, okay, what specific things may be beneficial for the mobility deficits? And there were mobility deficits that existed. Manipulation, mobilization of the cervical and the thoracic region based off of her impairments, and that makes a lot of sense as well to go through and do that. And then with the movement coordination impairments, giving specific exercises, and it says here combined exercises, and still supervised here in the clinic. So that was an example of how I want the grand rounds to go. Obviously, each time, this one was a little bit more difficult to follow, and I respect that because I was trying to articulate my thought process. Normally, in the classroom, what I would be doing is I would be answering as if I was the patient, and you guys would hear a lot less from me. So I hope that the commentary I added today was valuable, and you guys can pick that out as a benefit. My goal is I'm going to continue to talk less and less and less, and we're going to find ways to get this more interactive, and you guys are talking more, whether that's through discussions or through breakout rooms. So by all means, when you guys go through this, I am open to as much feedback as possible. You know, without question, you guys have been doing a lot of adapting over the last 2 semesters, and you know, your professors and I, we've been doing the same thing. So we want to make sure this is the best experience for you guys, as this is going to be a continued topic that we get into. So please, by all means, give me any feedback that you can. And you know, we'll continue to try to make this the best that we can. I hope you guys took a lot of great stuff from it, and I thank you for your attention. All right, have a great day. Thanks.